Welcome everyone. We're going to go ahead and get started. We want to leave enough time for our speakers today. Thank you for joining our Cardiology Symposium. The title of our symposium is Multimodality Cardiac Imaging from Diagnosis to Therapy Planning. My name is Frederick from GE Healthcare. I'm honored to serve as your moderator for this session. And to tell you a little bit about our agenda format, we will have two presentations, followed by a panel discussion. And let me go ahead and introduce you to our two distinguished experts and their respective topics. So first up, we're going to have Dr. Chiara Bucciarelli-Ducci. That's the little bit of Italian that I can pronounce. She is a consultant cardiologist and imaging specialist at the Royal Brompton and Harefield hospitals in London. She is also an honorary reader and associate professor at the School of Biomedical Engineering and Imaging Sciences at King's College in London. Since 2019, Chiara is the Chief Executive Officer of the Society of Cardiovascular Magnetic Resonance, headquartered in the United States. She is currently completing a master's degree in health economics at the London School of Economics. From 2016 to 2018, Chiara served as the Vice President of the European Association of Cardiovascular Imaging and the chair of the cardiac MRI section within the European Society of Cardiology. From 2018 to 2019, she was also the secretary of the EACVI. In September of 2020, she became the deputy editor, imaging section of the European Heart Journal. She is also on the editorial board and the Journal of the American College of Cardiology and Cardiovascular Imaging, Circulation Cardiovascular Imaging, and the European Heart Journal Cardiovascular Imaging. The title of her talk is Multimodality Imaging for Myocardial Assessment. And let's please welcome her now.
Thank you, Perry, and thank you, GE, for the invite. I think, it's fair to say that I'm passionate about cardiac imaging, and I've been doing it for a few years. And hopefully, I'm here to share some of my knowledge of what I learned during this journey, and how we, as community of physicians and imaging specialists, we can move the needle in using more imaging for patients with cardiovascular disease, and learn how impactful that is. So those are my disclosures. So the reason why I'm so passionate about cardiac MR, because since the early days, and I've been doing this for 20 years now, it became very obvious to me that doing cardiac MR is like doing in vivo histology. Essentially, by doing all this tissue characterization with cardiac MRI, we can really understand what's going on in the myocardium, and particularly in the dysfunctional myocardium. But we're actually learning that even the myocardium that apparently is working well, pumping well, actually there might be something going on in the myocardium that is not very evident. And when the heart is dysfunctional, maybe it's a little too late to find out what's going on. And so that really gives a lot of scope to do imaging throughout the patient journey, whether it's in the early days of the disease, like early detection, gives clinicians, cardiologists, the opportunity to treat patients, to do things. And you're going to hear from Gianluca's talk, the intervention, how imaging guides intervention. And the opportunity there is really to change the natural history of the disease, of these cardiovascular diseases, and with the ultimate aim of improving outcome, which is why we're all in the business of medicine. So I think this is very exciting, and this is very uniquely provided by cardiac MR. It's one test, many answers. I tell my students, just to be a little bit provocative and interesting. And so, the efficiency is intrinsic in the MRI test. Patient is there for half an hour, 20 minutes, 1 hour, depending how many images we need to take. But we can really look at many aspects of the heart. And CT obviously is an amazing test, but it's very kind of anatomical. With CMR, we are anatomical, but we are functional. It's a functional imaging. We see how the heart works and pumps, and but also is really the myocardial fibrosis that we see here with late enhancement and myocardial edema. Some are reversible damages or injuries, some are irreversible. What does it mean in terms of what we can do about it? And we can do ischemia testing, as you see here, an image, and stress perfusion CMR, sorry, it's here. So stress perfusion CMR is really, I would say, a disruptive clinical indication for these patients, because we can do this on top of the rest of the protocol. And so it's a very comprehensive way to go about and understanding the myocardium. And for all of you that do cardiac imaging, late enhancement is at the cornerstone of what we do. The contrast accumulates in the areas of the heart that are damaged or diseased, and it follows the pathophysiology of the process. And so when we look at these images, we do a pattern of recognition exercise. Is there contrast uptake, where it is, is subendocardial, transmural. That will tell us whether there's an ischemic damage or whether there's a non-ischemic damage. And we're learning, every day that different conditions have different patterns, and we're learning how to interpret them and how to be more sensitive and more specific. But the truth is that when you look at the guidelines, because finally this is what guides cardiologists in their clinical practice, they're really now mandating CMR, cardiac MR, in class 1. So for example, a patient with heart failure, which is a huge patient's population, there are various reasons why people have heart failure, so the etiology is very variable. But you see here that is now mandating for every cardiologist, for every patient with heart failure, that's what they have to do. In class 1, as you know, guidelines means you have to do it. You have to do it if you practice modern medicine. So there is really a call for action here. It says cardiac MRI is recommended in the assessment of myocardial function with echo suboptimal, which is not very often. But you will see here the CMI is recommended for the tissue characterization. And this is now on par with other imaging modalities, but actually exclusively and uniquely so. In class 1, to understand all this tissue characterization. And I don't want to bore you with the guidelines, but this is just a snapshot that the causes of heart failure, they're really multiple, different etiologies, but MRI features in every single of that, and those are those red circles. So it's really an opportunity there. And new sequences like T1, T2 mapping, this is the kind of advanced tissue characterization, and those are contrast-free sequences we take, but the late enhancement, which is post-contrast, really is the cornerstone of understanding that. And the latest and the newest guidelines is this cardiomyopathy guidelines launched in August 23 by the European Society of Cardiology. And there is cardiac MRI all over the document, in fact, to a greater extent than what I had expected. But you see, this is one of the kind of central illustrations, and you see the really pathophysiology and cardiac MR next to it. So it's really understanding what's going on. And here, more images. And there is a ton of indications, where and how and when to perform a cardiac MR. So here, to translate, make this less academic and more clinical, I brought you 3 cases of patients with heart failure. Those come to the cardiology clinics, patients with short of breath, typically. And you do an echocardiogram, you do a chest X-ray, which is what is indicated in class 1, you do an ECG. But also, if you practice modern cardiology, you got to do a cardiac MR as a baseline assessment. And so you will see now in this kind of diagnostic journey, we're going to take together how cardiac MR is really helping us. So these 3 patients, they look alike. The ventricles are large. They're not pumping very well, particularly the first 2. There is also left bundle branch block, which is this movement of the septum. So there is an ECG abnormality. You see the mitral valve is not closing very well. There's leaking, mitral regurgitation. So what is going on? So we're going to look at the late enhancement images together, and we're going to do a pattern of recognition, starting from this one. So you see, first of all, there is late enhancement over here. So there is some sort of disease process going on. Now, next step is to understand whether it is ischemic or non-ischemic, and it's very binary. Sometimes just do a pathology, but this is rare. And so basically, we know from the pathophysiology that if the late enhancement is subendocardial or transmural, that's ischemic, so it's an infarct, essentially. And if it's midwall or epicardial, so the inner layer of the heart to the outer layer of the heart, then it's nothing to do with ischemia, it's another disease process. And in this case, it's subendocardial, a subendocardial in the inferior wall, in the lateral wall, is also in the anterior wall, and so it's telling me that here is probably 3-vessel disease and infarct. Not all at once. I think it's, probably over the years. And so this is an ischemic cardiomyopathy. If next step would be to do an angiogram, and sure thing, in this case, we're three-vessel disease. And then the question is, should we revascularize and how? The second patient, let's see, it looks quite similar to the first one, but when we do this late enhancement exercise, well, at first glance, looks normal, but this is really about the attention to details. And I think the radiologists, the imagists in the room know this very well. There's really the attention to details that makes a difference. So if you scrutinize with the proper screen, with not all these lights, you will see that perhaps there is a very thin band of mid-wall late enhancement here. I'm not sure how well it projects, but trust me on that. And so this is mid-wall late enhancement. It means it's not ischemic. This is a dilated cardiomyopathy or idiopathic dilated cardiomyopathy. It could be a post-myocarditis dilated cardiomyopathy. I won't be able to say, the final etiology, but I can tell you here there is no coronary artery disease involved. And the third one, you see there is also some pericardial effusion over here. And obviously, the radiologist here with us know that you're not going to make the diagnosis on one image, but it's the image data set. This patient had a lot of lymphadenopathy, lung changes. He presented with arrhythmias and heart failure. And you look at this pattern, and this pattern is a little bit all over the place. It looks a little bit ischemic, a little bit non-ischemic. And putting all these findings together, particularly the extracardiac findings, I think what it rings the bell is cardiac sarcoidosis, which is a big mimic, actually, of an infarct on MRI images. But it's also a pathology that mimics myocarditis, but the sarcoidosis, it is a myocarditis. So it all kind of makes sense. But it's a hard diagnosis to make because it can be tricky. So we know from the literature that late enhancement is, so when it got developed in the US like 30 years ago, maybe 40, it was bright is bad, bright is dead, to teach students how to interpret late GAD, so because it was used for ischemic heart disease. I took the liberty to rephrase that into bright is bad, because it's not just for ischemic cardiomyopathies, it's also for non-ischemic cardiomyopathies, and also bad because is prognostically important. Having a scar in the heart is not good. It's a substrate for arrhythmias. There is some electrical heterogeneity in the tissue, and that creates arrhythmias, but also hospitalization. And so there is a ton of papers that says that late GAD is bad in every condition: sarcoidosis, dilated cardiomyopathy, hypertrophic cardiomyopathy. People will have more arrhythmias, and actually there is a link between the quantity of late enhancement and the cardiovascular outcomes. So, as you can imagine, it becomes quite interesting for cardiologists to know, how much of this late enhancement there is in the heart. And sometimes we can change management, but sometimes not, because, those studies still need to come. But it's an important information to have. So important that even, and you're going to hear from Gianluca, even to implant devices, we're using imaging biomarkers for example, in ICD, we use ejection fraction from echocardiography, the cutoff of 30%, 35%, but we're learning that actually maybe it's the wrong imaging biomarkers. We should be implanting a device based on how much scar there is in the heart, because finally the arrhythmia, it doesn't come because the EF is low, it comes because there is a scar in the heart. And so those studies are actually currently ongoing, so we still put a device based on EF, but it might well be the case in the future, meaning few years, because those results of those trials are coming up in the next couple of years, there might be a paradigm change on how we practice medicine. And so you see here in this flowchart of the guidelines already talking about late enhancement for the implantation of devices, and how important that is in the various cardiomyopathies, and obviously genetics is coming on board as well. So we're putting together the phenotype of imaging with the genotype, and we're learning basically every day there is different diseases. We can assess the dilated hearts, we can assess the thick hearts. And so we're not exclusive, but actually is a broad base of application here. And those hearts look quite thick, all of them, but actually have very different condition underneath, and the discriminator quite often is doing late enhancement. You see the pattern is very different. The first one is amyloidosis, Second one is an hypertrophic cardiomyopathy. The third one is a little harder diagnosis to make, certainly only based on late advancement, it's really challenging. You need T1 mapping on top, which is another imaging biomarker, then it's Fabry's disease, and this one is sarcoidosis. So why is it important at the end of the day to actually pin down the exact diagnosis? Because it has treatment implications. Some of these conditions are irreversible, like hypertrophic cardiomyopathy, you're not going to get cured of hypertrophic cardiomyopathy, but Fabry's disease, there are drugs that actually can cure patients or remove, the accumulation of the sphingolipids in the heart. And sarcoidosis also, you're not going to get rid of sarcoidosis, but there are treatments. You can detect the acute phase of the disease, the chronic phase, and there is treatment you can do. And if somebody has sarcoidosis but has been misdiagnosed and is been treated like hypertrophic cardiomyopathy, that's not good for the patient. So it's really important for us as imagers, to really refine our skills and trying to really be very precise in the diagnosis we make, because the implication is massive. And so ICD already discussed the ESC calculator at the moment. So this is basically a decision support tool for cardiologists, when to put a device in a patient like an ICD. And there are some imaging biomarkers. They're all echo-based at the moment. This is the thickness of the heart. This is, all these parameters you see here, the size of the left atrium. But I think, we're increasing discussion of how we include late enhancement in this equation here. And I think it's coming, and it's coming very soon. So going to move on. I don't want to bore you too much, but again, hypertrophic cardiomyopathy. What's interesting in hypertrophic cardiomyopathy now is not in the guidelines, it doesn't just say late enhancement, but says if a late enhancement is more, so the quantity of late enhancement is more than 15% of LV mass, that's a risk factor. And so maybe, a device should be put. And you see this number popping up there, which means we need to start including this number in our report. Which is just a new way to go about, but that shows how the field is moving fast. Constrictive versus restrictive is often a clinical request you might get, and it's a hard one to answer, certainly a hard one to answer with echo, and CMR plays a huge role, and this is a case of basic cardiac amyloidosis, and this is based on the late enhancement, which looks suboptimal, but this is not because my radiographer was bad. Sometimes it's the case, but not in this case. This is just the kinetics of the gadolinium is completely abnormal in amyloidosis, and that's how the image looks the way it does. Wrapping up, this is another condition. This is where amyloidosis and how CMR integrates in the diagnostic pathways also with scintigraphy, the PYP or PDP, if you're in the US or in Europe. There is a big role there, particularly actually early on in the diagnostic pathways, because the guidelines now recommend that you do an echo, and if there is left ventricular hypertrophy, you do a CMR, and then nuclear comes actually later. This is endocardial fibrosis, another phenotype of a cardiomyopathic process we can identify. So Fabry's disease, you see CMR featuring there. In other words, I think here the bottom line is that every single disease has its own cardiac MRI phenotype. Sometimes it's specific, sometimes it might be non-specific, but that's when it becomes crucial to actually link what we see with the rest of the clinical information, because sometimes the clue is in fact not necessarily in the images. And so the clinical integration is important. ARVC, arrhythmogenic ventricular dysplasia, I think it's a classic one for CMR, and the imaging biomarkers are ejection fraction and wall motion abnormalities. I think late enhancement is coming, and is actually coming already. The mimics of dysplasia, and I think this is, in fact, very often it's a rare disease to have ARVC. The mimics, and we need to be aware of that and just be mindful. I'm going to skip the clinical case, just not to bore you too much, but actually I want to show you the implication, non-sustained VT, in a young patient, then that's a perfect referral for CMR. And here you do a CMR, and you do the attention to details, and you'll see there is a bright signal in the septum, which, bright in the CNS is fat. And so there is a little hint, there is fat there, and there is here the demonstration that there is fat. This is a haste sequence. And basically there's fatty infiltration, and this then the ring-like pattern on late enhancement. We know now that it's basically this is left ventricular arrhythmogenic cardiomyopathy, which is sort of a new entity, not new because it's just newborn, but new because now we can see it and diagnose it. And that is genetic implication and clinical implication. Gonna just zoom off towards the end to say that then the new kind of tissue characterization, and this is the T1 mapping, T2 mapping, and the ECV for the various types of fibrosis. And by understanding the kind of tissue signal behavior of the different conditions, we can do differential diagnosis. And you see here different diseases have different patterns on those maps. So to conclude, and I think hopefully is a clear message that in cardiomyopathies, which is also heart failure, but it can also be ischemic heart disease, CMR is recommended in all these patients. And this is in class 1, and it's not me saying it, I'm passionate in the field, but this is actually the European Society of Cardiology. Why? Because there is a ton of literature that's what says. So it's evidence-based, in other words. And thank you so much for your attention, and those are my contacts, and keep in touch.
Excellent. Thank you, Chiara. Thank you. Okay, next up, we'd like to bring up Professor Gianluca Pontone, who will present image to guide treatment from revascularization to structural heart disease. To say a little bit about Gianluca, he graduated with honors in medicine in 1997, followed by postgraduate degrees in cardiology, radiology, and a PhD in clinical methodology in 2001, 2006, and 2014, respectively, from the University of Milan. He is currently director of perioperative cardiology and the cardiovascular imaging department of Centro Cardiologico Monzino in Italy, which is a research facility fully dedicated to cardiovascular disease. He is also a professor of cardiology at University of Milan. He is the author of roughly 600 indexed articles in international journals, as well as 7 scientific imaging books with an overall H index of 62. Finally, Gianluca is currently Vice President of the European Association of Cardiovascular Imaging and Chairman of the Cardiovascular Imaging Working Group of the Italian Society of Cardiology. Finally, he serves as Associate Editor or as a member of the editorial board of the following journals: JACC Cardiovascular Imaging, Arteriosclerosis, Journal of Cardiovascular Computed Tomography, and Eurointervention. Please welcome Gianluca.
Thank you. Thank you very much. We are now shifting from the diagnosis to the therapy that I believe is the new frontier of non-invasive imaging. And when we talk about the role of imaging in the setting of the planning of the therapy, basically we have 4 main topics. I will touch part of them because there is not enough time to discuss about all, but I will show the greatest novelty in this setting. And I want to show for a historical reason from this picture. This is the first invasive cornea angiography that was performed more than 50 years ago. He was John Sons, he was an interventional radiologist who did the first cath lab. That was the terrible image of a right coronary artery when they started. And some decades later, Andrea Grunzing performed the first PCI, that was the horrible images of LAD stenosis, in which the first PCI was performed. That was a very historical, from historical point of view, a very crucial point, because we shifted from the diagnosis to the therapy in the invasive imaging, and that was the shifting from interventional radiology to a specialized interventional cardiology. It is happening the same. You can find on the right side, on the left side of your screen, the CT in the concept of diagnosis, that is a left circumflex stenosis. And you have on the right side the virtual stenting. That is a stenosis, as you can see, of the LED. Then you can play with your tool and you can do a virtual stenting, and you can calculate the result of virtual stenting. You can calculate which is the expected FFR CT in case you treat the patient with that specific strategy. So actually we are in the same historical time point, just in a non-invasive setting as compared to the previous experience. When we talk about the non-invasive imaging to guide procedure, we are talking about how to guide percutaneous revascularization, how to guide surgical revascularization, how to guide structural heart disease. And this is probably the most famous field in which imaging plays a very pivotal role, and how to guide EP procedure, electrophysiology procedure. I will talk mainly about the first 2 points, and the last one, no time to discuss about structural disease, but also because now this is part of our daily practice. What about the first 2 points? How to guide the PCI. This was a brilliant idea that was taught by Carlos Collet. He's an interventional cardiologist who decided to share with us the idea to imagine how to use CT to guide the PCI. Indeed, for this reason, we started with this very appealing and interesting trial. This is the P4 trial, in which we have randomized patients with the indication for PCI in 2 different strategies. On one side, you have IVUS guided strategy. Let me just use the laser point. Oh, sorry. One, do I have no my? Okay, no, this is not. I have no my glasses. Sorry. The pointer I need. Or with the mouse I can use, or one. I can use the mouse or no? Okay.
Yeah, you can use the
mouse.
Thank
you. So. Patient with the indication for PCI, they were randomized to standard workflow, so I mean PCI IVUS guided, the usual standard workflow, or PCI CT guided. What is PCI CT guided? This is the algorithm that usually we are using. The patients are evaluated by CT, then first of all you use CT and FFR CT to do the diagnosis. There is a stenosis we have to treat. Then you use this tool to do a sort of a virtual stenting to predict the result. Then you use this information to decide which kind of catheter is better as compared to the other one, which is the best projection to do the stent implantation, which kind of material you need to prepare for your procedure. And last but not least, to have the procedure totally online CT guided. This is the package. I don't want to jump in details, but when we do a CT, basically we prepare this kind of package, and this package is in the hands of the interventional cardiologist in a virtual setting when we are in the art team to discuss about the case, and then in real time during the cath lab to do the procedure CT guided. Just to better understand, let me show these 2 examples that we did with the team of Carlos Collet. This is a patient in which we found, as you can see, a typical lesion on left circumflex artery. So there are no doubt that there is a high degree stenosis. In the same patient, the first information is to understand how the origin of the coronary artery is. This is a very important point because when the interventionalist has to decide which kind of catheter has to be prepared, during the cath lab, usually he do this. He tries to find the origin, the ostium of coronary arteries, but sometimes he has to change a catheter, then to repeat again, and so on. If you know perfectly the anatomy, you can start in advance with the appropriate catheter. For example, in this case, you can see that this is an unusual origin of the right coronary artery because it goes up, not it goes down, and the shape of catheter is different in this case. You can decide in advance. The next step is to understand the landing zone. The CT is able to see the wall of the coronary arteries, and we know perfectly what is normal to normal in coronary arteries. In this way, we can understand with the cross-section of the vessel that we need to cover from here to here. And what is also important with this dedicated color map, that we can understand the plaque composition. That means to treat directly the lesion with PCI or to pre-treat the lesion before to do the PCI in case we have calcified lesion. And this is another very useful information for the interventionalist. But the most important and interesting thing is to simulate which is the area at risk. Some dedicated software are able to understand which is the area that is supported by one specific vessel. And when you have to do a complex PCI, for example, you have a crossover, you have to decide if to protect or to sacrifice a collateral, you can know in advance which is the risk to generate myocardial injury, because you have a quantitative criteria to understand which is the risk to close or not, for example, one diagonal branch. Indeed, you can quantify, because we are able now to calculate the true area at risk is 42% for LED or 44% of left circumflex and so on. Then the next step is to move from anatomy to physiology. This is the reconstruction of our lesion on left circumflex, and this is the FFRCT of the patients. You can see here the FFRCT, this is the left circumflex. Okay, you can see very well that from fluidodynamic point of view, the hemodynamic impact is exactly in this region. And so for this reason, then you can calculate the pullback pressure gradient, exactly how you can do in the cath lab, because you have a virtual catheter that can goes back, and you can calculate point by point the FFRCT of the vessel. So now we have, anatomy on left side and physiology on the right side. Also, you can decide the best projection to have the most appropriate landing of the stent. You have not to try during the cath lab, put this projection, then I change again, no, I'm not happy, inject other contrast and I change. You can move the 3D, and you can decide that, for example, this is the best projection, and the projection is anteroposterior 0 degree or caudal 38 degree. And when you go to the cath lab, you put the arch exactly in the right position to start directly to treat the PCI, to do the PCI in the best projection on that. And after you have all this information, then you do the virtual stenting to say, okay, I want to put this stent. The result expected is very good, 0.98. So this is the best strategy. And you move with all this information in the cath lab, where you have in your screen on the left side the past, the fluoroscopy, and on the right side you have the future, CT to guide the procedure. And the CT is synchronized with your aortic arch in order that the interventionist can play and move the CT images, and the aortic arch is synchronized, and to do the entire procedure just by following CT dataset and forgetting in your mind the fluoroscopy dataset. Let me just move to a second example, more complex, because we have a lot of classification here. The previous one was very simple lesion, focal lesion, fibrolipidic lesion, no problem. This is a calcified lesion. And when you look, for example, the cross-section, you can see how much huge is the distribution of the calcification around the vessel. You can calculate also the density of the calcium. And according to the density, you can decide which kind of a preparation of the lesion you have to plan or not in this patient. This is the 3D reconstruction of your lesion. You can see very well that there are a lot of classification on that. And look at the difference between anatomy and physiology. The disease starts from an anatomical point of view from here, but the hemodynamic impact is after the origin of diagonal branch. So there is no perfect matching as expected in general. Again, here you have the calculation of myocardial at risk. And look, for example, we have disease of the LAD that starts from here, and from hemodynamic point of view start from here, and we have a diagonal branch in the middle. Which is the risk to close this diagonal branch? The risk is 20% of myocardial mass. So we have to protect this vessel. We cannot just with the qualitative approach to say, okay, this is small vessel, no small vessel. We have to quantify which is the mass at the risk. And then you can calculate with the pullback pressure gradient exactly which is the trend of the FFRCT during the pullback. This is a very innovative parameter that we are measuring to understand if when you have a lesion, you have to treat this lesion with PCI or with the medical therapy. Because if you have a pathologic value, but the PPG is very high because you reach this value very slowly, it means that you have a diffuse disease on the vessel. And the therapy is medical therapy, it's not PCI. If you have a drop-off, very clear drop-off of the PPG, this is a quantitative criteria to decide to treat the vessel with the PCI. And these are three different strategies that we can discuss in our team. This was the lesion. We can put just one small stent, 20 millimeter. The expected FFRCT is 0.8. Or we can decide to use a 48 millimeter stent from the proximal segment of LAD up to the middle segment, and the expected result is 0.82. Or we can cover up to the origin of the ostium of the LAD, but the result is the same, 0.82. So it does not make sense to put the stent to cover the ostium of the LAD if the result is the same, because when you cover the ostium, you need to protect also left circumflex. There is a not negligible risk to have a problem on the left main. So which is the best strategy? The strategy number 2. And we decide to go to do the PCI according to the strategy number 2. And that was the vessel that was treated, and this is very small, but you have the FFR in agreement with our expected result. But the second step is the use of the CT and FFR to guide surgical revascularization and not only PCI. And this was the experience of fast-track trial. This was a very innovative vision and idea of Professor Sir Rice, who decided to organize with us this kind of trial. What we did in this trial? The starting point is how we calculate the syntax score. For the people who are not expert in this field, but you know that when you do a cath lab in invasive coronary angiography, you have a 3-vessel disease, the guidelines suggest to calculate on angio the syntax score to decide if the best solution is PCI or CABG. And this is the usual workflow. What happens if we calculate the syntax score with the CT? When you compare the syntax score with the CT, usually is higher as compared to the syntax score calculated with angio, because there is calcification and we overestimate stenosis, and therefore the syntax score is overestimated. But what happens if you integrate the anatomy with the physiology with FFRCT? Okay, in this case, the syntax score is exactly the same of the syntax score evaluated with invasive approach. So if we were able to calculate the syntax score, we can use this to take a decision, avoiding cath lab, avoiding invasive coronary angiography? Yes, of course. In the syntax 3 trial, we randomize the heart team in 2 different groups. One heart team who take the decision based on invasive coronary angiography, traditional heart team, and one heart team blinded to the cath lab in which the decision was based on CT and FFRCT. And we compare the rate of agreement in terms of decision to decide for CABG or PCI. And the agreement was 93%, so very high. So we are able to look CT, to look the FFRCT and to decide, okay, is better CABG or is better PCI? And if we are able to do this, we are able also to plan which kind of CABG we can plan according to this data. Yes, we can do, thanks to the result of Fast Track. The paper is impressed on European Heart Journal, in which what we did, we use this kind of software in which we are able to simulate the CABG. We can decide, okay, I put the CABG here and I can understand which is the area protected by the CABG. Or I can do the anastomosis a bit more distal, and this is the projection. Basically, we can simulate the surgical approach. And after that, we can decide, okay, this is my proposal. Left internal Marian artery with an anastomosis here, venous graft with an anastomosis here, and so on. In this paper, we compare what was the virtual decision versus the real decision during the surgery. And again, the agreement was very high. So the last step is the use of CT to guide EP procedure, okay? This is another very emerging point. I don't want to spend too much time, but there are some very interesting novelty on that. You know that actually CT is able to do tissue characterization. It has not the same robustness of cardiac MR, of course, especially for late enhancement, but for quantitative tissue characterization, I mean extracellular volume and so on, the technique is very robust. You need to have non-contrast CT scan, angiographic CT scan, and then a late acquisition, okay? And then you can use exactly the same philosophy of a CMR. You can do a co-registration between an enhanced scan and a late scan to calculate the extracellular volume. you can do the extracellular volume. You can use this, and you can derive also the late enhancement by from the extracellular volume. You can apply this in several scenarios. One scenario is, for example, post-infarction, exactly like in MR, transmural infarction as compared to subendocardial infarction or no myocardial injury. You can use this also in other settings, like in ischemic heart disease. There is a prognostic value of the late enhancement with the CT, and it was validated in this setting. But for example, we have tested in a pluribus study that was published last year, the capability of CT alone to do the right diagnosis in cardiomyopathy as compared to the gold standard. The gold standard is the combination of CMR and invasive coronary angiography. And what we demonstrate in this paper, that the agreement between the CT alone, in which we evaluated coronary arteries and myocardial damage and tissue characterization versus the gold standard was very high, 94%, with a very excellent agreement. These are just some examples. So how we can use this kind of information to guide the procedure? Of course, when you have the entire portfolio, I mean MR, for the late enhancement, and then you have, for example, CT for the coronary arteries and for the fat distribution, and you are able to put all this information together, you have a huge portfolio to guide the electrophysiologist to treat the patient. This is a typical MR reconstruction to have 3D visualization of the scar. And I can, show you here. With this dedicated software, what you are able is to have a 3D reconstruction of the scar. This is a typical post-myocardial infarction scar. And with this software, you are able also to identify the corridor that is exactly the target of the electrophysiologist. If you merge this information with coronary arteries imaging by CT, scar if you have a good image quality, and fat, that is important information in case of epicardial approach, basically you can do a procedure that is totally imaging guided like this one, especially for the ventricular tachycardia treatment. This is a typical example of catheter in which you are treating the patient according to the information of the merged CT and MR. But in this case, we still need the fluoroscopy, we still need catheter. The next frontier is the use of radiotherapy to treat this information, because if we know where is scar, if we know where there are the corridors, and we have cardiac CT to center the patient for the radiotherapy, you can use radiotherapy to treat arrhythmias. And this is our experience at the STRAMI trial on the first 15 patients with a refractory ventricular tachycardia, no chance to do another ablation, and we did radiotherapy in this first experience. And this is the trend, the reduction of the event in patients who were refractory to the treatment with ablation. Actually, we have just closed the last patient 1 month ago. We have 1 year follow-up to close the experience of the STRAMI trial. And in case the result will be positive, the next step is to organize a randomized trial. So in conclusion, the value of CT in this setting is emerging for several information that you can have, as you can see here. And the advice is to not miss the boat, the bus, the train, or whatever. This is not my sentence, because of course this is my job, but there is a conflict of interest to promote non-invasive imaging to guide treatment. This is the suggestion that Patrick Seruis, who is an invasive cardiology, did to other colleagues, that if they want to be a modern cardiologist, you cannot skip non-invasive imaging in the daily practice. And I want just to remember this event that we organized as the European Society of Cardiology is a dedicated congress to CT and nuclear medicine that will be in Seville in May. That is a wonderful period for the Spain. So I hope that all of you will come to see the novelty in this setting. And a special thanks to all people of my department. Thank you.
Excellent. Excellent. Thank you, Gianluca. Thank you. Excellent. Thank you so much. Okay, now we'd like to transition into our panel discussion. So I'd like to invite our speakers back up to the stage, please. And we're also going to invite Martin Janik, who is GE Healthcare's Global Cardiac Applications Manager based out of Munich, Germany. So he'll join our discussion. So thank you again, Chiara and Gianluca, for your excellent presentations. I really like the balance between MR and CT technologies that you were able to provide us today. It was a really comprehensive view of where we are with the technology that we can bring to the cardiac arena. Maybe I'll start off with a question that applies to both of you. Last year, the European Society of Cardiology issued a statement saying that they and the EACVI support competency-based cardiac imaging services. How do you see the roles and responsibilities of radiologists and cardiologists in a collaborative way